Hi, everyone. So I have been asked to basically deliver the presentation I did at uh, the webinar that was organized by the ACLT, the African Academy of Leukemia Trust, a couple of months ago now, on gene editing in sickle cell. Obviously, a very hot topic, something a lot of us patients are talking about. So what I'm going to try and do is in about 20, 25 minutes, try and squeeze in as much as I can to give people a bit of an overview about what this is all about and maybe have a bit of time for some questions. So this is always where the challenge, I start to hold my breath and make sure the presentation projects. So give me a second. Here we go. So to move this. So ignore the date. So this is basically a conversation about Casgevy, which is the gene editing. So the way in which this was, I decided the best way to structure this presentation is with this in a series of questions. So the first one is probably the most obvious one. What is Casgevy? So Casgevy is also called Exosel. It's got a much longer name, which I'm not going to bore you with. It's a customized gene therapy product for not only sickle cell, but also for transfusion-dependent thalassemia. I'll explain how it works in a minute, or the impact of that is in a minute. But basically, it uses this technology which has taken medicine and clinical and academic research by storm over the last few years. The two scientists who identified this treatment, this CRISPR-Cas9 technology, received the Nobel Prize for Medicine. And effectively, what it does is for those patients who don't have a a uh, a donor for a variety of reasons, we won't go into that too great detail today. We can collect their own stem cells, modify those stem cells so that they start to produce in excess of fetal hemoglobin. And fetal hemoglobin is the hemoglobin that is produced while you're in utero as a baby, as a fetus in the stomach in the womb. And that is a non-sickling hemoglobin because the abnormality in the genetic code that gives rise to sickle cell disorder does not appear in fetal hemoglobin. So this is a non-sickling hemoglobin. What it also does is that hemoglobin also competes with sickle hemoglobin and mitigates some of the complications associated with sickle cell. Over and above that mitigation of the complications, it also increases your hemoglobin as well. There's good evidence, some evidence that we've been involved in that shows that getting a patient, as you would expect, getting a patient's hemoglobin up does improve their quality of life, but also reduces some of the complications associated with the disease as well. There are some challenges associated with this very new therapy. And what we do know is it reduces the breakdown of the red cell, the hemolysis. We do know that it reduces painful crisis. And I'll show you some slides at the end that shows that it reduces them quite significantly. But what we don't know is the impact of that on the long-term complications of sickle cell. And that's because, and I'll talk to you about that in a minute, basically because we haven't been using it that long. So this illustration, this was the first patient who went into actually the second patient, sorry, who went to the clinical trial. So just to orientate you, there were several hemoglobins that contributes this patient's overall hemoglobin. So this is old money. So in the UK, this is a slide from an American study. So they still use sort of everything in the tens. So hemoglobin is 7.2. And There's a small slither at the bottom, which is a hemoglobin A. There's a proportion, which is a larger proportion, 74%, which is in the sort of the, I don't know, purple, which is sickle hemoglobin. And then there's a small 9% fetal hemoglobin, which is in blue. After this patient has received gene ed has undergone the gene editing process, it's important to recognize that the fetal hemoglobin the sickle hemoglobin doesn't change. It still constitutes whatever that number was. Still constitutes a significant, not right, nearly over 50, almost more than 50% of the total hemoglobin. But what has changed is that the fetal hemoglobin significantly increased to constitute 43% of the total hemoglobin. That's really important when we come to the stage of thinking about the impact of this new therapy on patients, because what this treatment unfortunately doesn't do, it doesn't get rid of sickle hemoglobin production. The next question is this treatment, is Casgevy available to all patients with sickle? And this is the question I often get asked. Can I have this curative treatment? So for the time being, it's only available, the license means that it's only available to people with severe sickle, and we'll talk about what severe sickle cell is in a minute, who are over the age of 12. The license and the commissioning, so the NHS have said that we can do this for patients free of charge. The commissioning doesn't have an upper limit, but that being said, there are limitations because the clinical trials that sort of frame all of this only looked at patients up to the age of 35. As a sickle cell community, the clinicians, we've agreed that we will start with that cutoff. So though the license says it can be used for patients of any age over the age of 12, at the moment we're only using up to between those at the age of 12 and 35. That will likely change. We define severe sickle cell as patients who have experienced 2 severe crises per year for the last 2 years. That's a slight bone of contention, and I suspect that criteria will change somewhat for a variety of reasons. But that again is what the clinical trials use as one of the inclusion criteria, so that's what we're using at the moment. Patients that are eligible based on their genotype, so the SS, the SCs, the S-beta thalassemias. Unfortunately, because the clinical trials didn't include SC patients, only those who have HBSS and HBS beta thalassemia are eligible, which is another bone of contention. And Vertex, the company that developed this treatment, are in the process of setting up some trials for those patients who have hemoglobin SC. You need to be obviously fit for transplant, and probably more importantly is that we wouldn't offer this treatment if you have a fully matched sibling donor who's willing to donate stem cells. The reason is that is the gold standard treatment. So we know that that treatment it's the least toxic, and in many ways the one we have some of the most data on. So if you did have a fully matched sibling who's willing, then that will be the option that we would recommend to you. So to explain the journey, the learning is quite, and this is a bit that I'm probably going to just rush through because it's quite complicated. One of the latter slides does have a link to a website that's been developed by the pharma company that's created this treatment. And I would encourage you, for those who are interested, to go to that website and go through it step by step. It's an animated thing, and it's also got a really nice voiceover as well. So it goes to the process in great detail, which I don't have time to go through today. So I'll just go through this quickly. These all slides from this. So the first step, as you would assume, is just making that decision about whether this treatment option is for you. and it's intense. I'm not going to sugarcoat it. It is quite intense. It involves some risk, and it's quite a long. There's a lot of downtime. So that we for standard stem cell transplants, we suggest it's going to take between 18 months and 2 years for you to get back to yourself. Well, a year to 18 months, I should say. For this treatment, it's significantly longer, and I'll explain why in a minute, because it could be up to the 2 years before you are through the whole process. It's more intense at the beginning, and then things get less intense, but it still is quite involved. It will start off by, and we try, and we don't always possible to do this because for a variety of reasons, but we prepare the patient for collection of stem cells. And ideally what we would want the patient to go on to is a transfusion program if they're not already on one. And that puts the stem cells, the cells that we're going to collect and modify, in the best state possible so that the collection process is optimal. So that starts with that's over 2 to 3 months. There's several exchanges to prepare you and your stem cells for the journey ahead. After that, we collect the stem cells, and the stem cell collection in sickle cell patients can be quite challenging. It does involve a line into the groin to facilitate the stem cell collection. And one of the issues with sickle cell, because the disease itself does it can be quite aggressive to the bone marrow. It does make the stem cell collection a bit more challenging in sickle than other patients. And that can require repeated sessions for collection of sufficient stem cells for the process. So it is not without its challenges in that regard. Then once the stem cells are collected, they are sent to an external lab to this company where they modify the stem cells. And I'll go into any detail, but effectively what they do is that they induce those stem cells to start to produce an excess of red blood cells that contain significant amounts of fetal hemoglobin, as I explained earlier. And this can take up to 6 months. So that's 6 months of waiting patiently for that process to be completed. So that's something that those patients that we counsel need to be fully aware of, because that's a long time to wait. And then the patients get admitted. So we've given them some red cell exchanges to get them ready and the stem cells ready. We collected those stem cells, we modified those stem cells. And then before we can give them back those stem cells, we have to clear the bone marrow so the stem cells are well received. And that involves chemotherapy. So quite intensive chemotherapy that is delivered over a few days. Obviously, you need to be admitted into hospital for that. And that can be as long as 6, but sometimes even longer, up to 8 weeks in hospital for that process to be completed. That time, as with most chemotherapy, the blood counts will go down and the risk of infection is very high. You will likely require some blood products, so platelets and possibly red cells to get your blood counts up. And that chemotherapy does have impact. So with some of the other treatment options, I've used the example of the fully matched sibling transplant. That doesn't involve any chemotherapy, and the impact on fertility is low. This is likely to make those patients that we offer the treatment or receive the treatment infertile. So something that I didn't talk about is a fertility preservation that would happen during the phase, that 6-month hiatus, and we would do that then. All being well, the patient would be discharged after about 6 to 8 weeks, and then there's a post-transplant period where the patient comes back to hospital very regularly to be seen in clinic and in our day care unit for blood product support, assessments, adjustments of medication. So the intensity is quite heavy at the moment. At the beginning is a couple of times a week, sometimes more than that, 2 or 3 times a week. But that, as with the medication burden, that will fall away as you get further away from this transplant. So I've kind of sort of rushed through that to a certain extent because I realized that we haven't got a great deal of time. But I would like to sort of direct you, those who are interested, to this website, as I sort of mentioned earlier, which gives you as I said, a very nice sort of walk through the whole process with a bit more detail than I have to give you today. Are there any questions at this stage, or should I just keep on going? I think that's probably keep on going. So the next bit is just to give you an idea about the post-transplant follow-up. It is really quite intense. Oh, there is a hand. Ade? You're muted.
You're on mute.
I'm just really looking at the criteria for severity in sickle cell. Does that mean that if you have a crisis, you need to come into hospital for it to be recognized that it is severe?
So it's a very good question. This is something we often sort of discuss. So basically what you do need to do, you don't necessarily need to come into hospital. You need to you seek healthcare advice. So going to your GP in those circumstances is sufficient. I can see your smile. It's not perfect, and it's not, to my mind, I actually don't think that it's fair. So, but based on this criteria, just to give you an example, based on this criteria, patients who have severe sickle and start on an exchange transfusion programs, and because they're on an exchange transfusion program, they're not coming into hospital all the time, they wouldn't be eligible. It's just absolute madness to my mind.
Okay.
So we are petitioning to get clarity on this because I don't think it's fair because you're on treatment. It makes you ineligible for a treatment, this option that would likely transform your life. So yeah, that's something that so for the time being, it is those crises need to be documented with a healthcare practitioner. Doesn't necessarily have to be hospital. It could be a GP or an ambulance or something like that.
Okay, just to round off, I just wanted to know about the different types of time that you come to hospital. I know it's a very long process, but if probably maybe to summarize, how long would you need to be in the hospital over this 2-year period?
Oh, so you start. So there's that 2-year period. That includes the start. So those bits that I just went through. There are those various steps. The 2 years. So that's probably about the first 8 months. So the exchanges, and then the collection, and then that's 6 months, up to 6 months. It isn't always 6. It's between 3 and 6 months where they're manufacturing these modified stem cells. That is so that's probably about 8 months, that whole process, 8 to 9 months, and then after that, it's you have a 6 to 8 week period, so another couple of months where you're in hospital. And all being well, then you have you come back and forth regularly, as I said, initially 2 to 3 times a week, and then that starts to tail off, and you start to reintegrate with society. There's a few slides about that in a minute, but yeah, so that's really how it is. So it's commitment. Let's put it that way.
Okay.
And we need to make sure that's clear to patients because it is a massive commitment. There's another hand from, I assume that's Fee.
That's me, yes. So my question relates to when they've sent off the stem cell for it to be modified, what percentage of trials have come back where something's happened and they can't use it and they may have to get more stem cells again?
So the number of questions. So there are a proportion of patients who we can't collect sufficient amount of stem cells to start off with. So just to preempt that, as I said, it's more with sickle than other patients. It's about 20% that we can't collect enough stem cells, and as a consequence, we can't even go through the manufacturing process. And then another proportion of patients, what about 15%, that the manufacturing process fails. Now, the way in which it works is that they don't go back. Invariably, you're unlikely to have enough stem cells for us to go back after we've had 2 or 3 collections to try again. So effectively, if those 2 processes fail, then the whole process has failed. We can't really proceed.
And what is set in place for individuals to deal with having been told the process has failed and you're not able to have the treatment?
So one of the things which I'm going to come on to is psychological support. Psychological support is critical, not only for this type of transplant, probably most important for this type of transplant, because there's going to be even up, if everything goes smoothly, there's going to be long periods of downtime where not much is going to be happening. And that can create a degree of anxiety, concern. So we've done a few of the conventional transplants before, and that time-wise is significantly less sort of involved. And even with those, we've seen psychological issues that developed as a consequence of that. So what we've done, I can only speak to Imperial, I can actually speak to all of them. So all of the centres, and there's been a national sort of steer to try and increase psychological support to this patient group, because we realise how much of a psychological impact the whole process goes. Those are that's for those patients so it's successful. We in the clinical trials, and we are now sort of setting things up for this option to be available in NHS. There is a need, and there is funding, national funding, to support increased psychological support for patients. So that is something that has been highlighted on multiple fora, and certainly something that I strongly advocate. We really, really do need to keep a close eye on patients, because this is potentially quite devastating if things all fail.
One last question. You mentioned that they are looking at trials for SC patients. Do we have a date when that will convene?
We don't.
Okay.
So we will be involved in those trials. Exactly when that's going to happen, I don't know. I know that they were setting them up about 12 months ago, so it's potentially imminent. I haven't met with a meeting with them in the coming weeks. I can certainly ask that question, but I don't know.
Sorry, I know I said the last question. Now, how does one know if one is fit enough to be able to consider this treatment?
So certainly wouldn't expect patient to make that assessment. So what I encourage you to do, if this individuals to do, if that's something you would be interested in, is to have a chat with your clinical team. Part of the process requires some quite intensive assessments of lungs, heart, kidneys, liver, all the organs, to make sure that you are physically fit. And as I sort of alluded to before, there is quite a lot of psychological assessments way before the trial starts to make sure you're psychologically fit. And we have built in some social support, because one of the things that the trial, and I was going to talk about this a bit later, is that the trial does limit your ability to interact with large groups. Sorry, the transplant does limit your ability to interact with large groups, and especially in the early phases. So that will have implications for work and sort of the ability to sort of offer sort of financial support to yourself and to your family. So that all those things need to be weaved into the process to make sure they're properly covered.
So in other words, hurry up and win the lottery so we can get this ball rolling. Thank you.
Oh, well, me. You will never see me again.
Patients in general.
Oh, I see. It's none of this is not really. I guess there is and I've talked about this with the drug company. There's a lot of hidden costs with all of this, and the social support, the psychosocial support, I think is really, really important and needs to be sort of embedded in this process. And it's not just with this Casgevy. Casgevy is effectively is a modified stem cell transplant. All stem cell transplants require a period of withdrawing from society, and that has a significant psychological and financial implications. And I don't think those have been fully recognized and the implication of those. So we're working hard to make sure that people are not negatively impacted. People are not avoiding this option because of the financial implications that they have. So that's one thing we're trying to do. But yeah, no, all really good questions.
Thank you.
Ade, is that a new hand or an old one?
That's an old hand.
I know you got technology issues, so it's fine. Okay, I'm gonna whiz through the last few bits. Actually, I'll try my best to whiz through as quickly as possible. So post-transplant follow-up. This slide just tries to illustrate some of the big issues. So the reason that we see you initially 2 or 3 times a week is for regular blood work, transfusion support. As I said, red cells, platelets, the clotting cells, all these sorts of things initially will need to be sort of topped up until the bone marrow starts to embed itself and starts to work properly. Patients have indwelling lines, which I didn't talk about, and those lines need to be maintained during the process. And the medication it shouldn't be sort of underestimated, the number of drugs that patients need to take, especially in the initial phases. Things to prevent other things to increase things, all sorts of medication, and compliance to that medication is critical. And unfortunately, infections, as the immune system is immature, are an occupational hazard. It's likely to become a potential complication. So we make sure the patients are vaccinated post-transplant, but initially the risk of infections is high. So we encourage our patients when they show signs of infections to present very early and get appropriate antibiotics as needed. How does this differ? I'm not going to go into this in any great detail. How does this differ from other types of stem cell transplants? There's a whole series of things here. Just to highlight a few quick things, is that whether this is a cure. I know that it was sort of in the media, this is banded as a new cure for sickle. Because we have limited data, I think a lot of sickle cell doctors are hesitant about calling this a cure. We know that it, and as I said, I've sort of promised this slide about showing how the impact on painful crisis decreases significantly following this treatment, but we don't know the impact this has longer term. The first patient who received this therapy as part of a clinical trial was just over 5 years ago. So we've got about 5 years of data on that patient and subsequent patients. We've only been about 46 patients, maybe slightly more than that now, who have gone through this treatment option. I know that those in the Middle East are doing these as part of their, outside of the clinical trials now already. I was speaking to a colleague from Bahrain who they're already doing this. They've already done their first and second. So, but these are still small numbers compared to some of the other treatments that we have, the fully matched sibling transplant, the haploidentical transplant in sickle, where we have decades of data. This is very different. It does have disadvantages. And yeah, so I'll probably leave this slide there. As I said, I have limited time. What are the benefits of Casgevy? So this is the slides. These are the 2 slides that I was talking about. So just to orientate you, so along the side, you've got 44 patients, 44 number of patients is 44, and there are 44 patients who, as part of the clinical trials, have received this treatment. Each line, each horizontal line is a patient. In grey is the pre-transplant, the 2 years before the patient received the transplant. In this case, it's a number of severe crises. So the diamond represents an episode of severe vaso-occlusive crisis in a patient with sickle cell. So you can see in all cases, it's peppered with these diamonds in the grey zone. I don't know what colour that is. I don't know, salmon? The salmon, and then the blue colours, or that period where the patient received their transplant in the sort of the early stages of recovery. And then the interesting bit is the green area. So this is the post-transplant period after they've had the treatment. And in all but a couple of cases, well, 4 cases, none of these patients have had any crisis post-transplant. We're not entirely sure, and I've asked this question of the company, why some of these patients continue to have, though few, they continue to have fatal crisis. Most of them are the consequence of severe infection. Some of them are patients who developed COVID, and that stimulated a vaso-occlusive crisis. Interestingly, as I said at the beginning, this does not remove sickle cells. The sickle cells are still there. It just reduces them as a proportion of the total hemoglobin. And as I said, fetal hemoglobin limits their impact. This slide is slightly cleaner. Again, it's sort of the same criteria. So 44 patients, each line is a patient, and this is the number of hospitalizations as a result of severe vaso-occlusive crisis. And again, the diamonds are very frequent in that grey area, and then highly infrequent. And this patient again is that third patient who had COVID. These are very infrequent after they've had their transplant, had Casgevy. So it's without a doubt that these patients do much better. They have fewer crises, they don't no longer require transfusions. They have fewer hospitalizations. But this is one impact of sickle cell. There's a whole series of other things that hadn't been assessed as part of the clinical trials because they take years, if not decades, to develop. Obviously, doing a clinical trial, it's very difficult in that context. However, the drug company are continuing to monitor patients. There is a clinical trial which is monitoring the patient over the next 35 years to see the impact of this treatment in relation to those long-term complications. To my mind, one of the most important things is, obviously, we talked about the physical impact of this treatment. What is also important is psychological impact. I'm going to bore you with details, but basically, these are 3 quality of life scoring systems, and they look at slightly different things. So this is why they did all 3, and they showed that in those patients who received the stem cell, who received this treatment, this Casgevy treatment, they did statistically so much better. Their quality of life indices was so much higher than they were before they received the treatment. Kind of a no-brainer, but in all honesty, we needed to have this data because it's all well and good getting the numbers up and making and showing the impact from an academic perspective. These are real-life implications. This is a real-life impact of this treatment for patients. Is it safe? I've got a couple more slides, so I'm gonna whiz through this. Is it safe? The answer is yes. As long as the patient and none of the patients have the disease has relapsed, it is safe. They've had no deaths. Yeah, thank God. And apart from a patient who actually who developed COVID in that period before they actually received their treatments. And unfortunately, that patient developed respiratory failure and unfortunately died from succumbing to disease, but they hadn't actually received the treatments as yet. Otherwise, the side effects related to the chemotherapy to prepare the bone marrow for the receipt of these modified stem cells. I'm not going to go with this energy to sort of touch on all of this. I think the important thing to highlight here, the ones we talked about, the psychological impact and the impact on fertility, which have to be really carefully considered. With this one, just to highlight here regarding infections. So initially, the big risk are bacterial infections, but as time goes on, viral infections become more significant. And just the arrow at the greater than 365 days relates to the fact that sickle cell patients in this context are even a year on increased risk of developing viral infections. And this is why we sort of instruct them to avoid large areas of highly populated individuals for at least for the first year. So the last things, so a few things I often get asked, whether stem cell transplants involve an operation. I have no idea why there's so many typos in that sentence. And the answer is no. I often get asked this, and I think I've been asked this in this form at one point, whether having a stem cell transplant, because this is a stem cell transplant just like any other, whether that can cure, whether it cures your sickle cell, but that's yes, but whether it still increases you can still pass the sickle cell on to your children. The answer is also yes, because the stem cells, only the stem cells are modified here. The gametes, the eggs and the sperm still contain the genetic abnormality associated with sickle cell, so you still can pass it on to your children. We talked about the upper age limits and whether it's a cure. We talked about that also. So my key messages are that this is a new and exciting treatment option, but not without its risk, like with any stem cell transplant. But also, there is an anxiety about the fact that we don't, as yet, have enough data to say that it reduces the risk of these long-term complications. The assumption is that it will, but we don't really work with assumptions. So we need to collect that data, and that data is being collected as we speak. The journey, the Casgevy journey, is a long and complicated one. So it requires an understanding, a commitment from the patient. And we kind of touched on this before. We need to ensure that there's equity of access to these treatments. There are 6 centres that are able to deliver this treatment in the UK, 4 of which in London, which would suggest that there may be some inequity there. That being said, 70 to 75% of all sickle cell patients live in London. So it's understandable that that's where the focus of these centres are. What we don't want to happen is that there are pockets in London that don't have access to this treatment, and also pockets nationally that equally don't have access. And then, though this is a great treatment option, it's not perfect, and it's not perfect for everyone. There'll be a cohort of patients, a group of patients that this isn't the ideal treatment. So we need to be able to offer them something. So we need to do more in developing new treatments for sickle cell patients. And I think that's where I'm going to leave it. Any other questions? I'll stop sharing. Deathly silent. Fee.
Stephen, I think the misconception for a lot of patients is that for those who have been saying it's a cure, what they don't understand is that if you've had stem cell or gene therapy, your genotype will remain the same. If you've had issues with any of your organs, it'll still have those same issues. And I think until we start projecting the information out there that says, yes, it will reduce the episodes that you have, but whatever's damage or any issues going on in the body completely caused by sickle cell, it won't change. So if you've got a heart condition, um, that will still remain. If you've got proteinuria, it will still remain the same. It's just the episodes that's literally gonna stop.
So, Fee, a couple of things to say on that. It's a very, very good point. So, it depends on what stem cell transplant you have as to whether can be considered a cure or not. Regardless of which stem cell transplant option you receive, whatever damage has been done, this isn't a time machine. It's not going to take you back in time where you didn't have bone damage or you didn't have liver damage as a consequence of your sickle or lung damage as a consequence of your sickle. That, unfortunately, if it's there, it can't be reversed. And this is why I think having this sort of treatment available to a young age of patient, so you can treat them before these sorts of things happen, is really, really important. So that's the first thing. Also, the point about the stem cells and you've been able to pass it on is another thing, another issue, but probably equally. So we do consider the other stem cell options, so the half-matched transplant, the haploidentical transplant, and the fully matched sibling transplant as cures, because we have data over decades to say that they are cures. So we can say they are cures with all those sort of provisos saying that actually they're cures, but if you've got organ damage, that's going to be there. It's a cure, but you can still pass it on to your children. So it's not a cure in the sense that the disease has gone. In that regard, there's still consequences of that. The only difference with gene editing is that gene editing, we haven't got enough data as yet to even call it a cure in that very limited scope, because we haven't got the long-term data. So your point is one that's actually really, really interesting. And we need to get those messages out because they're really, really important. And people need to be clear, because these are really intensive things. What you don't want to do is someone not be fully explained to them that what you're going to get for the amount of time and effort and risk that you're letting yourself in for. So yeah, there's a massive educational piece that needs to be done. And though the media were very good at putting this out, and it's great for them to be talking about sickle, these situations all sensationalized. They say, oh yeah, for a great new cure, but that's limited in its scope. Ade.
I think there's kind of a little bit of confusion for me. I mean, I think you've been clear in terms of what you have explained. My issue is more about this rush to call something a cure. Okay, because in my mind, what most sickle cell patients need is really how we do the care bit. I know the care is nearer the cure, and the drug companies are actually looking for the cure and everything. But really, we are living beings. So I think that is the care bit that one needs to actually start looking at. But my question is that I think sickle cell, and this is really my experience, which is probably just really to me, that I think my crises are almost always triggered by infections. Okay, so if I live in a more septic environment, it means that I can ward off the infections. And I'm wondering whether if somebody who lives in Africa, where the sources of infections are many, whether giving them a lot more fetal hemoglobin will actually resolve the issue. I mean, will it stop malaria, what do you call it, the mosquito bites from causing malaria? And does this provide us with more immunity so that even if the infection comes, you can fight off the infection? That is where my mind is going, and I'm just really asking this as, yeah.
Ade, there's a lot to unpack there, to be perfectly honest.
Okay, sorry.
So that's okay. No apologies at all. So as far as increasing fetal hemoglobin, reducing the risk of infection, that is so there were drugs that will do that. Hydroxycarbamide, and this is something that we talk about not infrequently. The hydroxycarbamide increases fetal hemoglobin, and it does reduce the risk of sort of septic episodes. Okay. Because for a variety of reasons. But it's I lost where there were a whole heap of questions there, so I may have missed a couple of things. But I think if we can get to the point where we're using hydroxycarbamide more efficiently, more effectively in, I was going to say in Africa, actually, not just in Africa, in the UK. And Patrick is working with me and others on a project to try and understand why there's such a great reluctance to hydroxycarbamide. So I slipped that in there. So there is a treatment that can sort of increase fetal hemoglobin, and I think that's really important that we don't ignore that. Sort of that clarion call at the end about trying to get the drug companies more interested in developing more drugs for sickle, I think is another important option, because some patients sick hydroxycarbamide, for whatever reason, isn't the most effective drug for them. We need to develop new drugs that work, that have been properly trialed, and can reduce those risks both here in the UK, in sub-Saharan Africa, and everywhere. So there's a lot of things to say there. I think the trigger thing you talked about is also really important, but I mean, I kind of feel like there's hands up everywhere, so probably need to move on to the next question. But it's a really interesting point. But I think the first thing that I would say is you really need to make sure that the hydroxycarbamide is fully utilized, and at the moment it isn't.
Okay, thank you. I mean, I just sort of thought to ask. Okay.
No, it's good questions. I don't know if it's Georgina or
Patrick, me. It was
okay.
Right. It's my really hands up. I thank you very much, Stephen. I know you're extremely busy, really, and it takes a lot to come and do a presentation after a long, really shift. Thank you very much. I don't think that you're appreciated nearly enough in somebody's opinion, and in my opinion, definitely. And this is a great intervention, a great new thing for sickle cell, a great new treatment, which is up to now, we're not sure if they'll cure it, but we assume it will be a cure. And it's great. And I think, although it's far from perfect, I would like to see hundreds of treatments, because sickle, as most of us know, everyone is really so different. Okay, so we would really like to have hundreds of treatments. So we got to accept this and really do the best we could utilize it, as we should other treatments and drugs like hydroxyurea. My concern, one of the concerns I have really, Stephen, is the fact that look at the psychosocial or psychological sort of involvement in this on your presentation. I think probably it's a true representation. I don't think it's nearly enough, because really what most people like to see is from being involved with the psychological support before and during and after, because all through this is so new, and having a sort of dealing with many sickle cell patients from a patient perspective, you know, they've got so much to deal with ordinarily and they don't get the support, I do believe, ordinarily. However, with this, it put them in a different place, and they already sort of, they will have highs and lows throughout. Right, and they need that support, and I do believe that if they had effective patient involvement throughout this sort of bringing out this sort of standard of treatment, I think the psychological support would be greater involved in this. So maybe that is something you could work on among all the other things you're doing. And also, when you consider that there is maybe 18, 19, 20,000 people with sickle cell in this country, these treatment, is so specialized, and it's so sort of non-available to the massive population, sickle cell population. I mean, apart from it's over 12 and under 35, there's still perhaps you're talking about 30 or 40% of the 18 to 20,000 patients. So all this is great. What do we say to them? What do you say to them? Those others. And that is really, it's not easy question, but I want to have your thoughts on this.
Yeah, no. So again, very good questions. My dream for sickle cell is to be able to offer, because this is a complicated disorder that works in a really unique way. And I think one of the failures, certainly the failure of crizanlizumab that was drawn from the market, is it targets a very small element of the way in which sickle cell disorder works. And that, I think, was its downfall. And my dream is to have multiple drugs that work together that combat the disease in different ways. And then we have a suite of things that we can offer to patients based on their age, based on their genotype, based on their severity, their complications, sort of a whole, rather than just saying, okay, you have hydroxycarbamide. If hydroxycarbamide works, fantastic. If it doesn't, then you've got blood transfusions, and that's pretty much it, which is really where we are at the moment for the vast majority of patients. You want to be able to offer people a whole variety of things. Like I sit in an office with doctors who look after patients with hematological cancers, and they have tens of drugs. And obviously, I'm not, and I was going to say, obviously, I'm not comparing this to cancer. In many ways, it's just as severe. And the quality of life and the impact of the disease, in many ways, is not dissimilar. But we've got one drug for sickle cell. And that is a big issue. And this is why we need to do more. We need to educate people more. And that's the things that we're doing with the Alliance and the Imperial Sickle Cell Group to try and sort of change that. But also, you talked about psychological support. I think psychology is just an underrepresented field generally, but particularly in sickle cell. In most centres, I trained at Guy's St Thomas's, and Guy's St Thomas is fairly unique where they have a team of psychologists who work within the service. That's unique. Here we have one. This is Imperial. We have at Hammersmith, so we have one who serves about 500-600 patients, and the same at London Northwest. It's not enough. It's not even close to being enough. We need to increase that 4 or 5-fold. So I just think that these sorts of things are, and then the final thing about availability, I think we need to be mindful of. I agree that we need to make sure that we serve the community in a holistic, equitable way. But the problem is the expertise isn't widespread. You, as patients, you know better than I do. Patients and advocates, you know better than I do. That the understanding of sickle in itself is limited to small pockets within the city. This is London, where there's a high density of sickle cell patients. Sickle cell transplant is even worse. So what we certainly don't want to do, and I think one of the things that the commissioners did relatively well, is that they only allowed the treatment to be available in places where they had the expertise in sickle and in transplant, because they realized that was something that was necessary. that being said, we probably do need to expand both those things so that we can deliver this more widely. And there was a push to try and do that. There was, and that's probably it. I hope that answers your questions, Patrick.
Very much for us, really. I think we got Laurel, who's waiting patiently.
Yeah, I was going to say, thank you so much, Stephen. If you don't mind me asking, how much of these kind of presentations do you do on the gene therapy, like what you've done today overall?
Oh, so this particular presentation is the second time I've done it.
This really,
I
think it's awesome. I think it's an amazing presentation. I think the way you come across and the way you've presented it is fantastic, because I agree with you. When it first came out, the way they were saying, there's a cure for sickle cell, there was a cure for sickle cell, I think a lot of patients actually really thought that, it was a cure for sickle cell. And I also know that a lot of people didn't also recognize how traumatic the whole thing is going to be, what was involved in it. The reason why I asked you that is because that you're really educating, because for somebody like me who knew the basics of it, but listening to your presentation, I fully understand everything about it now. That presentation needs to really go everywhere. I know you're only one person and we can't clone you, but it's an amazing presentation. And I like the way that you came across, because you made the presentation real. You made sure that you touched on, what the treatment is about, but you also talked about how invasive it is. And I think that's really important. Same as what you were saying about hydroxyurea. I mean, I've been on hydroxyurea for 15, 16 years, and it took me a long time to actually be persuaded to go on hydroxyurea. And I have to say, I've had quite a good spell on it. People just need to be educated. I think they just need to be educated, but also people also need to be willing to go on trials and take part. We can't complain that there's not enough treatments if we ourselves are not willing to come forward and take part. Nothing's going to ever change if people are not willing to. You know how easy it is for us to complain? It's so easy to complain. It's so easy to talk about the things that are not going well. But instead of us complaining about just the things that are not going well, we need to support the things that are going well. And we need to try and also improve things for ourselves as well. Otherwise, it won't change. But I had to say, your presentation was amazing. And I think that's the presentation that needs to be, even if you can't do it, train some people, train some patients, train some people to be able to do that presentation to other people.
So thanks so much for your words. The one thing I would say is that the full presentation was delivered, and it was it's on the ACLT YouTube channel. So you can watch it if so people do want to watch it, then you can access it that way.
I don't think it'll come across the same as you delivering it, because you
I did it. I did the presentation. Yeah. I did the presentation. That was the first time I did the presentation. So I'm happy. My wife and children singing to deliver this presentation wherever. Yeah. And as you know, so I think it's really, really important to people to hear about sickle. And I think more generally than this, I think the thing about so don't get me wrong, and I think I probably overstate this bit, that this is not though this isn't a perfect treatment.
Yeah.
It is a good first step. I think there are things that we are looking into, and so we're working with Professor McCarney, Julia McCarney on because one thing, whenever I think of sickle, I think of this global impact of sickle, and where sickle is most greatly felt isn't in the UK, it's in sub-Saharan Africa, it's in the Caribbean, it's in the Middle East, it's in various places where it's in India, sort of the Asian subcontinent. So there are various places, some of which are low and middle income countries, and they can't even consider this treatment option. So what we kind of need to do is develop treatments that aren't going to cost, because the the basic price tag on this is £1.5 million. I suspect the NHS got a very, very good deal on this. Certainly, they haven't reduced it by more than half. So this is a big expense. And you can't expect this to be that burden to be taken by a country like where I'm from, the epicenter of sickle cell disease in Nigeria. They can't do this. So it's a good first step. It's a good treatment option, but we need to think about other options that can cure patients without the big price tag. And being able to do things like they're doing for haemophilia at the moment is what we call in vitro gene editing, where someone gets an injection and and it packages the CRISPR-Cas9, the thing I talked about, and it sends it to the stem cells, and that's all done within the body.
Wow.
So you don't have to take the stem cells out of the person, manufacture. This is where all the big costs come from. It's taking the stem cells out of the person, manufacturing the stem cells, and then returning them back to the person. That's where the expense comes. So if you can bypass all of that and somehow be able to deliver this to the place of the body where it has its impact, then you can reduce the cost of this sort of treatment dramatically. And I think these are the sort of things we need to think about. Over and above the other thing you said that I think was really, really impactful about clinical trials. As sickle cell community, we really, really, really need to engage with these companies, not think of them as the enemy, because a lot of people said, even some of I was at a meeting and one of the drug company reps came and said, oh, sorry, apologizing for the fact that she worked for a drug company. Some of the drug companies done awful things. Yeah, don't get me wrong. But unless we engage with them, we're not going to be able to progress things with this dream that I have that we have multiple treatment for sickle. Unless a drug company is going to develop them, or drug companies are going to develop them, then that dream will never come to reality. So yeah, it's a really, really good point. And thank you for your kind words. But yeah, we have work to do. Is there anything else? I can hear some voice.
Yeah. Now it's I think Cami got a hand up.
Danielle.
Danielle, can you share with us your?
Hi.
Hello.
Yeah, I'm not sure if I missed something, but just one of your answers had me wondering. For patients like me whose bodies did not react well to the hydroxycarbamide at all, like we had to immediately come off it. Does that mean we would also likely struggle to be able to have the chemotherapy? Because I had a doctor say to me at the time I tried it as if it was like a low dose chemotherapy pill in some way.
So without knowing the ins and outs of what happened with you, I don't obviously I need to sort of say that to start off with. I think it's a common misconception that hydroxycarbamide chemotherapy is. So can be used in the treatment of some cancers. Well, actually, it doesn't actually treat them. It just reduces some of the blood counts in patients have very high counts as a result of their cancer. So it's technically not chemotherapy. I guess that's the first thing to say. But the second, probably more important thing to say is that purely because you had a reaction to hydroxycarbamide doesn't mean, unless there was something unique to that reaction, I can't think of a reason why that wouldn't exclude you from having access to a transplant option, whether it's gene editing or one of the other ones. So I would encourage you, if this is something you're thinking about, to have a chat with me. I like to hope that as sickle cell doctors, we're generally quite approachable. I have no idea. I certainly am, I like to hope. But I think I'd like to hope that you could approach your team and say, actually, I've heard about this new, and this is what I have almost every single when this treatment was, because we were the first country in the world to have this licensed. And when that happened, the next week in clinic, every single patient was asking me about this. Clinic lasted forever. So I think most sickle cell doctors expect to be asked these questions now. And I'd like to hope that if they're not able to ask the question, they would refer you on to someone who could. And I'm getting a lot of referrals from centres in and around our region who are asking, okay, can you meet this patient to discuss their transplant options? And I think I always accept them because I think it's a very reasonable thing to do. Why would you not want to have a cure for your sickle cell if that's something that's an option for you?
I've actually aged out. I'm not eligible, but I think
So-
that's why at the time I was given such poor information about the hydroxycarbamide.
So the age thing is specific for gene editing. If you are, I would, if you're interested in, stupid question, interested in a cure, almost everyone would be, but I would have the conversation. There is no harm in saying, by the way, I had this meeting. They talked about curative options, and can we explore them? They may say no. If they say no, then you've lost nothing. But they may say, okay, if you've got siblings, if you've got other family members who could potentially donate, then those options may still be available to you. So we're just talking specifically about gene editing today, not about all sort of transplant options. So just, I'm sure you. I don't know whether I can't even see your face. I can't see how old you are, or get an idea. You're probably 90, but you look 25. But my point is, don't limit your options because, as I said, these discussions are things that most sickle cell doctors are expecting. So don't feel like you can't have the discussion with them. And also, I would sort of, going back to Laurel's point, though there are cutoffs for some of the clinical trials, there may be some clinical trial options available to you. And if not at your centre, there may be some in other centres in the region. So explore all options. And unfortunately with sickle, because there are so few treatment options, we're trying to put as many patients as we can into the clinical trials because there's not much else. We give them blood transfusion. If they can't have blood transfusion, then we offer or hydroxycarbamide, that sort of stuff. If those aren't options for you, then you're kind of priced out. So clinical trial is really only other thing available to you, nothing. It seems really quite sad, really, but this is where we are. I don't know if that was helpful, but I'll speak to your team. That's really the message.
Thank you. I mean, Sonia was chairing this meeting, so and she was doing a wonderful job. She just seemed to have not.
I think she apologized and we're overrun, so she's probably had to leave.
Oh
no, I'm still here. I think it's
she's still
Amy
here.
that's left.
Oh, yeah,
great. So I mean, you're
I
chairing.
switched
you
my
do a
camera
wonderful
off because
job.
I was having
Just
connection
continue.
problems.
Continue, Sonia. I mean, I'll round up in the end, if you may, but please continue.
Okay, I don't think there are any more hands up from what I can see. There were some comments in the chat, but I think that's kind of, we've passed that level now. I had dropped a message in the chat in relation to totally agreeing with all that Laurel said, and it would be good to have that recording to be able to share across all of our other support groups as well. And indeed, you've spoken at ours before, so
Yeah.
very useful.
Right.
And I've also mentioned the kind of the cost benefits, because everyone goes £1 million, but actually when you think about it, it's not a cost that translates, because if you can't work for the most of your adult life, then you are then actually a cost to the NHS, to adult social services, to social security, and all of that. You'd have done that in 10 years, £1 million in 10 years. So if you don't work for 40 years because your condition is so severe, do the maths. So
exactly,
there is no £1 million is nothing.
Nothing.
It's so, getting them to agree that it's worthwhile doing as many of these treatments as they possibly can.
So just a couple of things to say. One, I think I said George's name wrong, which is apologies for that. The second thing is, your point about the health economic impact is so important. So the impact on communities, sort of patients, people who have psychosocial impact of that, not working and things like that, all massive. And that's not even including patients who are on exchanges and they have to come in every 4 weeks for blood. They have hospital admissions for sometimes several days, sometimes weeks. They end up on ITU. It's a massive amount. Some people could burn through that £1 million in a year.
Oh yeah, I'm sure.
So I think it's a really important thing. And one of the projects several projects we're trying to do is trying to collate that data. Because one of the reasons why the sickle cell application for Casgevy got rejected initially, this is why our first patients are probably going to be the transfusion-dependent thalassemias, because they got NICE approved in December. It wasn't until after the new year. So February, I think it was, the following of this year. So there was a period where actually in many ways, I was convinced, because I'm so jaded by the services now, that it was going to be rejected. So what we need to do is build that data, understanding about the impact of disease, because I agree with you wholeheartedly that it has significant impact on society. Those costs have never been factored into any of the equations because no one's collecting them. So one of the projects we're trying to do is to try and collect that health economic data, as well as the impact on primary care, secondary care, all these other things. So that next time we have a drug available or another treatment available, that data is freely available, and we can, there you go, NICE, you can have it. And don't reject any more of our drugs.
Yes.
I mean, I could see the passion, and I could see the really practical things, steps that ought to be taken, and it's not. And you again mentioned part of the things, Stephen, along the way, is the really lack of expertise, and not only it's increasing, but it's increasing fast enough. I don't know, but also, again, grateful for you because you're part of the transplant team, or lead the transplant team in Imperial. And I mean, you couldn't do a better job in many ways. And we just pray that you could, with your what shall I say now, ability to invite people that will be more similar to you, with your vision and insight and knowledge, to really increase this sort of area of expertise. And again, I can't thank you enough, because you're always available to come, and you all explain things in sort of patient-friendly manner, which again is a skill which not many people have sometimes, right? So I'm grateful for that. You can't thank you enough. Thank you.
No, I thank you. Thank you for your comments, but that last bit is really worrying. And this is one of the things that I think is really important, because I think, and I was in a meeting last week and we talked about this specifically, and I know it's over time, but I think it's really important, is that a lot of the things that we say in a way that patients and patients who unfortunately sit at the bottom of the pyramid, but those at the top, the people that make decisions about where the money goes, we're far too elitist in the way in which we discuss things. So as a consequence, it goes over patients' heads, but also goes over the heads of those people that hold the purse strings. And as a consequence, we kind of get priced out. No one discusses, no one thinks about sickle. It's changing, to be fair, but we just need to keep on driving that agenda forward, because we really, really need better treatments. This is a great start, but it's a start. So we just need to keep on driving the agenda forward. And the reason I come to this group and talk to you lovely people, is that you're always very engaging, you're always very supportive, and you're always very inspiring. So you go back and you think, actually, I'm going to keep on doing more. So yeah, anyway, I'll shut up there and let you close the
Before you
event.
go, I mean, I think one of the last thing that we haven't mentioned, I mean, as you mentioned it, because I'm part of the hydroxyurea project we're trying to really to really do. And I come back to the members here. Unfortunately, I was hoped that we had a flyer, because we would need your help. We would need your help as being part of the team that will steer us in the project. Pass to the team that reviewed what we're doing is really what it's required, because it started really from this group about 2 or 3 years. Some of them I don't remember, but about 2 or 3 years ago, from the steering group comments, they asked us to be, if we can involve in it. And now we starting a project. We've been funded for it, but we need your help and support. When I have the flyer that is really fit for purpose, in as much as got all the necessary information, I will from Georgia, I was cascaded around, and also invite you to join us in with your expertise and your knowledge to guide this project, because it's one of the few projects that's been led by sort of patient group. And although Stephen here is the clinician lead, really he takes a back seat in many ways. And we've got Rutendo, also one of the co-leads as myself. She is a great researcher and academic. And we've got the team with Laurel and Fee and Sonia now, and others that really help to support us. So we really aim to be successful in this, have something that's really we be able to increase this sort of uptake with hydroxyurea, right? But we need all the help we can from this group to really push it and to see to completion with something that really fit for purpose. But I'll share all the information soon as I get it from this group. That's the last thing, I think. Is there any other views or comments you would like?
Yes, Patrick, just want to say, as you're roping me into this, it's extra chocolates for getting involved. Sonia's already shared hers, and I've got a choice to pick from. So, I'm not doing it for free, Patrick. Unless you're giving me chocolates, you can forget about it otherwise.
Listen,
what you say, Stephen?
I
Candy
will buy
for
you chocolate if there is a cake on the 19th. If there's no cake on the 19th, forget it.
I'm not baking.
Wow.
Forget it. Okay.
Wow,
It's his way of subtly telling us.
Worst
It's
order.
his way of subtly telling us it's his birthday too, Stephen.
Before we go, anyway, we haven't heard from Chanel. Chanel, come on, we haven't heard your voice. So tell us what you think, and what if you got something to share with us, something new, or what you think so far of today's meeting.
Oh, hi, everyone. Can you hear me?
Yes.
No, I was just checking in. I was just sitting back and just listening to the meeting, and I feel like the presentation was really, really good. And yeah, but someone also mentioned something about there's not enough psychological support, and I definitely agree with that. So I'm out of breath because I'm just walking back home. But what I did want to say is recently I did have an appointment with my sickle cell nurse, and she did come home, and I did give the opportunity to literally go over certain questions and to go over how I'm feeling. And I know they have the funding for the Southwest teams and everything, but I do wish that there was more more appointments, more home appointments, because I literally got an opportunity and the chance to literally go over what I'm going through, but also when my nurse asked me what I'm dealing with and how my treatments impact me, especially with regular blood transfusions, I didn't even realize that I wasn't really coping that well. So I just think, with the psychological support within the sickle cell community, I think that is very scarce. But I was just, listening in, and just grateful that I'm able to listen in the background, and grateful that the group is still, doing amazing things. So that's all from me.
Well, thank you, because what we'll do with that, we'll make a note of that. And as you know, if the psychologist from Imperial comes again, or if really you feel we need to take it further, I'll take it to the steering group, because those things are really important and not to be really dismissed. We've had Adassa and also Eugene, but I think Adassa slipped away because I think she probably aware that, this group is our voice, and everyone has a voice. I want to make sure that everyone got opportunity to really have that voice and be confident, because it's a safe place. So whenever issue comes, we could raise it here. So really, our voices are all equal. There's no one more equal than the other. So if there's something else from outside, or would you notice it within the presentation or everybody else, look, we want to make sure that you have that voice, exercise that voice, right? And only with like that, as a group, we could really be more united and able to tackle all issues. Stephen, you got your hands up again. Back to you.
Yeah, so it's a really, really cool point. Just to really comment on Chanel's points. I think the impact of transfusions is something that I think is woefully underestimated. So I think it's really, really, really important, and I hope you can get the support you need to sort of help you through that. But yeah, I just wanted to emphasize that impact of, because the impression is, and I think as clinicians, we often think that, okay, you're getting the transfusions, life must be fantastic, but often there's challenges during that, before, soon after,
And we are,
and then
yeah.
you're in that period just before your next one, then the cycle starts again. So it's far from perfect. And this is why we need the other things.
Yeah.
And the final thing I was going to say is that I'm just putting that presentation, so it's quite a long, I think 2 hours, in the chat, so that so you can access that talk that I contributed to. So it's in there now.